the other topic. Erkan Kaptanoğlu is with us. So he's going to talk with about the sacral fixation techniques. Erkan Kaptanoğlu.
Yes. Can you hear?
Yeah, we can hear you.
Okay, thank you. Thank you for inviting me here. Hello, everyone. I'm going to talk about the, let me just screen share. Yeah. Can you see me, right?
So it's full screen now. We can see and hear you.
Okay.
Wonderful.
Sacral, I'm going to talk about the sacral fixation techniques, a little bit anatomy, very short, and rational, and sacral fixation techniques, and one case of lumbosacral fixation and iliac fixation techniques, and some tumor cases that we should go down. Actually, when I saw this picture, I thought this is more than I thought, actually. More ligaments that fixing lower lumbar to ilium and the posterior pelvis as in anterior part. So we have a strong lumbar, sacral, and pelvic fixation. So muscles also support this fixation from the lateral, anterior, and posterior. So when do we go down to the pelvis to fix it? L5S1 listhesis, spondylosis, to correct pelvic obliquity, sacral distractions like trauma, tumor, and infection, or better to get a better corrected sagittal deformity imbalance, and to long lumbar instrumentation with past L5S1 surgery, disc degeneration, and stenosis. This is what literature says. So, what is the technique? This is how we enter, where we enter the S1 screw. It is inferolateral part corner of S1 superior articular facet. This is the entry point, and then this is the direction. Most popular direction goes to anterior promontorium. If you pass the promontorium, it is called tricortical fixation, and we should go medially. I will show you the studies, because when you get older, your ala is getting weaker and weaker, comparing to body of S1. So there are some studies, they put screws lateral, medial, or and straight into the sacrum, and then they get best results with one goes to the body and they enter the anterior cortex. Of course, those two screws are stronger. And this is one of my cases. It's about 25 years ago. When I do operations, I had difficulty in entering the S1 screw because of the posterior iliac ala. So to direct the screw anteriorly and medially, I had to cut this posterior part of the superior iliac, posterior superior iliac spine, as you saw here. So we published it, and we found almost 15 to 20% of males have this problem. So this is another case. This is the entry point of S1 screw, and this is the iliac, posterior iliac spine, like a wall, obscuring the direction. And then we cut the iliac spine, and then we can get a good diagonal direction to the anterior spine of S1 here, like here, and then this is screws goes to do anterior part. S2 screws and sacroiliac screws are almost popular. The starting point is S1 and S2 foramens, and then when we go laterally, and enter the iliac bone, it's sacroiliac screw. S2 alar screw also. For the iliac screw technique, we start with the posterior superior iliac spine. Usually we prefer to go just above the sciatic notch because it is one of the strongest place in the ilium. Then we can put another screw to the top, to the up. There are some degrees that measured before, but I usually prefer to measure it before the operation. Okay, lumbar degenerative case. This is a case I use it in my presentation for just to give the idea. The patient has a cell-positive sagittal balance. Try to throw himself backwards, and then he get a flat thoracic vertebra, less kyphosis, but that wasn't enough, and patient bent his knees and retroverted the hips. So that wasn't enough. So patient has serious back pain, walking distance is low, bilateral root pain. This is the MRI. We saw here the foraminal stenosis L5S1 and the stenosis at L2. So we need to decompress the spine, and then for the balance, we need to put some extra instrument, and we have to do. We needed some osteotomy for the take the vertebra backwards and to give the lumbar lordosis better. So this is sacral chordoma case. This is 32-year-old engineer, computer engineer, difficult urination and erection problems, male patient. You see the tumor is here. The tumor, this is the CT scan, three-dimensional. Tumor occupies the spinal canal, and there is no there is no actually way to save the roots in the sacrum. Actually, this is biopsies was a chordoma. So we did a total sacrectomy, L5S1. We cut because the tumor goes up to the L5S1. Here, fixing the ilium is depend on some factors, and the iliac resection is important. Yes, there are many good studies about the sacrectomy, instrumentation of sacrectomy. These shows actually on this study is quite similar results. Like this is like this one, that is what like this one. The more you put, the better, the slightly better results you can get. This is the idea. But factors that may affect the fixation, not the fusion, weight of the patient, bone quality, sacral bone left in surgery, quality and width of ilium, how the leftover, distance between posterior iliac bones and lumbopelvic fusion. We have to do fusion. There are many custom-made products. So we remove the tumor of this patient. This is the chordoma. So we get surgical margins are negative, and we put screws like L3, 4, 5, and iliac screws, and the one graft between ilium. Patient is good after the operation. Let's see. And this is after 6 weeks. The instrument is here. This is, we skip We skip S1 because we don't have S1 here actually. For this kind of tumors, if we remove, this could be enough. I only changed one of the patient's road in 2 years, and then he is good. This is a giant cell tumor. This is almost the same kind of implant fixation we have done. 45 years old mate. He has a diagnosis 5 months ago. He had an embolization 3 months ago. No good progress. Last 2 weeks he cannot urinate and cannot defecate and had a slight neuro deficit. And he had a huge tumor here compressing the rectum, push anteriorly, and then bladder pushed anteriorly. We had very difficulty putting the catheter in here. So we embolized the patient again. We prepared like 45 units of aortic suspension, and then we start from the posterior. It was very bloody tumor. We remove posterior side by piecemeal, and then we start going anteriorly. We saw the rectum, and we went anteriorly and remove all the tumor, and then we save most of the sacral roots. One side we lost S3 and S4, so but it didn't change didn't give us any nerve deficit. So we put almost the same instrument here, one iliac screw here, one iliac on the other. We put always a connector to close the posterior pelvis. This is why we do this, why we put very few instruments, because there are some pieces of sacrum, and this has a connection, a joint with the L5 vertebra. So this patient needed nothing after the operation. With the fixations, he was very good. So this is a sacral sarcoma. This is we are getting more instruments and more fixation in this kind of patients, because this is a sarcoma. Sarcomas are usually on one side. I don't know why. I saw a lot of left-sided sarcomas. So we plan to cut from here and from from ileum, because there are tumor island in the iliac wings actually. So this is one side, left side up, and this is the sciatic notch here. We cut the ileum from the sciatic notch. We removed the tumor with the sacrum and ileum together. So we ended up with this hardware structure. We studied before the operation. We needed to get a T shape of connections. We don't have T shape. We didn't have T shape connectors here, so we have to do one, another, and then we turn. So we put two in one goes to almost into coxa, and here, and the other here, and the other. So we were very lucky in this case. We didn't get any infections, and in 2 weeks we sent the patient home. So pathology was sarcoma. This is another sarcoma case. This case is different because this is more lateral, and we have to remove more iliac bone. So biopsy was sarcoma also. This is one side, left side was up, and then we opened the posterior sacrum all the way to the coccyx, and then we cut the one side of the tumor, left side, because the tumor on the left side, we're going to cut the left side. And if we preserve one side, patient is going to be functional after the surgery. So we cut from here. This tumor went up to L5 vertebra. So we remove L5 and sacrum with the coccyx, and then with the muscular gluteus maximus muscle also. And so the pathology, the sarcoma margins were negative. And here the plastic surgery helped us to put fibula, bony fibula graft, because we thought the defect is very, very big. So we needed a fusion for this case. So this case were also discharged. This is the last case. This is the first I'm presenting. This one had the tumor went up to the L4, but it was in the muscle here, in the paravertebral muscle, not in the bone. And then here it goes into the sacral bone, and then it is a huge tumor only on left side, on one side, and in the sacrum. Biopsy was sarcoma, and we removed the tumor. This is sacrum, all the sacrum, and this is muscle. Went up to the L3, I believe, L3. This is the pathology. This is the where the tumor is in the muscle, and this is the sacral bone with the tumor. This is chondrosarcoma. Surgical margins are negative, as we know. We have to be surgical margins are negative. So we, because we failed. In first case, we had to change the roads. So we thought we have to support from down to L5 to push the L5 up a little bit. So we hadn't we asked producer to produce an instrument with T shape, and then they did it for us, and then we put it, and then this is also one side, and the other side iliac screws. So we put a iliac plate to prevent when the patient gets up to prevent posterior iliac opening. So after 2 months, a patient has get a loosened instruments like this, and then the instrument we put here with this angle was out, and the screws were out. It was sorry, it was like everything was out. The patient was his mobilization was inappropriate actually, but we have to. So we saw the posterior iliac, posterior pelvic opening caused this, and then we make a revision. We put this instrument from posterior because this is more vertical now, and then we put 2 screws, and we put a new stronger stainless steel plate here. So he's better so far. So the instrumentation safety for strategy for sacrectomy should be determined on a case-by-case basis. So we cannot estimate 100%, but there are of course some rules. What I have learned from sacrum for years, a spear screw must be strong, medially directed, and B or 3 cortical. Check closed posterior spinal iliac spine preoperatively. It helped you very much. It helped us. Oh, sorry. If it is lumbosacral fusion, interbody fusion is a must at L5S1. If you're going to put screws S1, please do interbody fusion with bone or cages, whatever. For the lumbopelvic fixation, double iliac screws with double rods should be better. Total or extended sacrectomy, lumbar iliac bony fusion is crucial for long term. Thank you very much. Thank you.
Kaptanoğlu, thank you so much for this perfect presentation. So let me ask you a question. When you decide to stabilize the lumbosacral joint, which part of the sacrum, when you decided you have to need a fixation for that part?
What is your question actually?
My question is that in this distal part that you're removing from the sacrum, especially in the sacral tumors, okay?
Oh, for the tumors.
Yeah, you don't need to make any fixation. When do you decide that you need a fixation? If you let some part of the sacroiliac joint, do you consider?
Yes. According to the literature, if you can save 1 out of 3 of sacroiliac joints, you don't have to put the instruments. So I try not to put the instrument in sacroiliac in lumbosacral area if we don't need it.
So another question, when you're doing gray tumors like sacral tumors, you put a mesh to prevent the posterior part of the intestinal system. And do you have a trick? Sometimes there is a leakage there. It's not cerebrospinal fluid, or it's not a fluid coming from the intestinal system. When do you say that it will disappear in time to patient? What's your
Okay.
yeah.
Um, there's a plane. There's a plane between the sacrum and the rectum.
Yeah.
If you keep that plane safe, you don't have to put any mesh. But if this is why general surgeon says, because of their experience. But if rectum, when you remove the tumor, rectum goes back, whatever you do. In any case, because the gas in the rectum and whatever, I don't know, rectum comes back. I like to put a mesh in between. Dacron mesh usually, or whatever, synthetic mesh. The fluids comes from the skin incision after the operation. It is usually seroma. Seroma is a lymphatic fluid. Sometimes starts after the operation, even sometimes lumbar operations, we see seroma. It is not an infection. It is like a CSF. It is colorless fluid. So for the seroma, you have to compress the skin. You have to compress the wound to stop the seroma, because they called it as there is a lack of closing the lymphatic channels. So, but here you have a gap, you have an empty space, and it is very difficult to compress the skin. And skin is very, very sensitive to necrosis.
Kaptanoğlu, thank you so much for this valuable experiences. Suat Canbay from Turkey has a question to you. In a giant cell tumor, would you consider shrinking the tumor with denosumab treatment first, then surgery can be done more safely? You can also read it on the right side, on the bottom.
Okay. I can't read it, but I understand the question.
Okay.
We don't do any I don't know any study about the pre-off use of denosumab of giant cell tumors. Maybe Suat can give us some clues about this. If we can remove everything, so we don't give any denosumab. If we cannot, sometimes it goes to the coccyx, or it behaves like a malignant tumor. Yeah, we should.
Okay, Kaptanoğlu. And another question, I think Ben can answer this question from Turkey. Vehbi Gülmen. L5-S1 fusion may cause sacroiliac joint pain if iliac screws are added to L5-S1. Sacroiliac pain may occur in lower rate or vice versa. So Vehbi Gülmen is asking if the iliac screws are added to L5-S1 fusion, may we reduce the sacroiliac pain or vice versa?
Adding sacroiliac joints were shown to be affected, so they could degenerate faster if you add the L5-S1. So actually, the load hypothetically on the sacroiliac joints will increase, and in one of the articles that I cited, it was demonstrated. And then the authors there also added sacroiliac fusion separately, and apparently treated it well.
Any other question? So if you don't have any question, Yahya has a question. Kaptanoğlu. What do you think about autografts such as fibula graft or MTRA after sacrectomy?
Yes, it is. It should be. It should be. Yeah, actually, we need something. We have L4, L5, L3, and the sides of these vertebrae, and cut L5, and then we have wings. We have posterior iliac wings. So we have to put in between. It is iliac bone is very fibula or iliac strip, like a patch, like a pan, okay, or finger. We have to put something like this, okay. In last two cases, we had a iliac strip bones like this, and when we put in between L5 and L4, between L5 and iliac and L4 and iliac, underneath the rods. So iliac fibula is a little bit long. You need the amount of fibula is a little bit long, so it is recommended to be the live fibula with the artery. So fibular graft taking is, yes, it is good, and we have an experience with this. But after 12 hours of operation, plastic surgeons takes the patient, and then it takes like 5 or 6 more hours. It depends the condition of the patient.
Thank you so much.